Good to be here. It's really an honor and privilege for me to be here. I look back on my 2 summers at SMI with just a lot of fondness. It was a really good time for me, not just to learn what it meant to be a Christian in medicine, but more than that, just to understand the gospel a little more deeply, understand my sinfulness, understand the importance of community. And those kinds of things have stayed with me over the years. So really grateful to be back here and to be speaking to you all. This is going to be somewhat informal. You guys should feel free to ask questions as I go. I tried to leave time for questions at the end, so I think we should have time for that. I've given this talk the past couple years, and I've pared it down a bit because I feel like a lot of people know a lot about COVID at this point, and so I tried to focus on the areas that I thought were most relevant to you being here during summer. Can everyone see? I know I'm blocking here. Can you all see? Sort of? No, not really. Maybe I'll sit off to the side. Okay, we'll do that. All right, so here's what I'm going to talk about. Current state of the pandemic. We'll talk a little bit about masking and vaccinations, prevention efforts, and then end on quarantine and isolation guidelines. So hopefully this is a chart that a lot of you have seen before, right? So these are case counts across the U.S. of COVID-19. And the important thing to note is these are officially reported case counts. These are, of course, underreports because there's lots of people who are asymptomatic or mildly symptomatic who never got tested, and people who get tested who don't report their results. And that's particularly true, I'd say, from here onwards. So from January onwards, there's been a lot more use of rapid testing at home. A lot of people are just using rapid tests at home to diagnose themselves, and those results don't get reported. So I would say this is really a gross underestimate. It's probably at least 10 times more than that, probably more on the order of like 20 to 30 times more than what we're seeing there. Just looking at the past year, we had our Delta wave there, and then I'm sure you all remember Omicron, where it just felt like everyone in the U.S. had COVID at that point. And then we got to pretty low levels at the end of February, beginning of March, some of the lowest levels of the pandemic, and then we had the Omicron subvariant show up, which I'll talk a little bit more about. All right, so this is Philadelphia, and again, these are official case counts. And on top you see the number of negative tests reported. This is the number of positive tests, and this is the percent positivity. So of all the tests that are reported, what percent are positive? And what you see here is towards the end, this is the last couple months, right? There's been an increase in positives. There's been a decrease in the number of negative tests reported, which tells you that people aren't really testing enough, at least not officially testing enough. And the percent positivity has increased a lot. So that tells you that there's a lot more positives out there than what we're seeing. The good thing is there is a downslope towards the end there, so it does look like cases are trending down at this point. So these 2 charts, these are maps of Philadelphia, and so these 2, what we call heat maps, show you the testing rate per 10,000 residents and the percent positivity among those tested. And these are for all time, right? So I put an arrow for the community that we're in, and you can see in terms of the level of testing, it's been pretty low here, and that's not surprising given the neighborhood that we're in, right? But in terms of the percent positivity, it's been pretty high. So this is a community that's had a lot of COVID, but hasn't probably had access to a lot of testing throughout much of the pandemic. So now that our official case counts aren't really that accurate, they're not great metrics to go by, we have to look at other metrics that might be more accurate. And so hospitalizations might be one of that, but that's just really pointing at severe disease. And so one thing that sort of caught fire over the past couple months is actually looking at wastewater surveillance. So you can actually look at the sewage system and actually test it and see how much COVID is in the sewage system. So they're doing this across the U.S., and the CDC is partnering with some companies to do it more broadly. But this just shows you what's happening in different parts of the U.S. If you look at the Northeast, that's in the sort of yellowish orange over there, you can see we had a pretty high peak over there compared to other areas, but now we are trending down as the official case counts show. So you might see more of that in the future. All right, so what's driving these waves, right? So typically we get a surge when either one of 2 things happens. Either it's a new variant that comes along that a lot of people don't have immunity to, or it's the winter. So we've had winter surges in the past 2 winters, pretty significant winter surges. But over the past 6 months or so, it's really been the winter surge and the development of Omicron, right? So Omicron was sort of a gut punch, and it was sort of a very different variant than what we had seen before. because it could bypass a lot of the immunity that we had. And that was both immunity from people who had infection in the past, as well as immunity from the vaccine. And that's what led to that really big spike that we saw between Christmas and New Year's. And so then we got down to low levels, and so what you see here is the proportion of different variants that have been in place across the US since March. And so these two shades of purple here are the original Omicron variants that were there over the holidays, right? So between the end of December and beginning of January. And since then, there's been a series of successive variants that are really within the Omicron family, but they're mutated a little bit. And they're mutated to the point that they are more transmissible than the original one. So the reason each of these variants keep taking over is because they're more transmissible, they're more contagious than the variants that came before them. And the reason they are, for most of them, is because they can evade our immunity a little bit better than the variant before them. And so we saw BA2, which led to a wave, and then BA2.12.1, and that's led to our current wave. And now you see there's another two variants that are coming up that started in South Africa, BA4 and BA5. And so how this will impact our case counts in the US, not really clear yet. It may prolong the wave that we're in, so you saw the sort of down slope there, and so it might plateau at a certain point and it might go on further, or it could potentially lead to a little bit of another surge. There's a lot of immunity that's developed when all these people have become infected over the course of these months. But unfortunately, for the people who were infected over the holidays, right, over December to January, that doesn't necessarily give great immunity to the variants that we're having now. So we're seeing a lot of reinfections now. People who had COVID in the past, getting COVID again, and even people who just had COVID over the holidays who are getting COVID again from these newer variants. And this is just another way of showing the different variants that have been prevalent over the course of the pandemic. So the original strain was called the Wuhan strain, and then in early last year we saw the Alpha variant, and then in the summer of last year the Delta took over, and then Omicron came out of nowhere and took over, and then since then it's been transitioning more frequently. There will be a limit to this. There's a limit to how much a virus can mutate and become more transmissible. This is not going to go on indefinitely. But it is converting faster at this point. All right, so a sort of better metric, one that's more reliable, but is really just focused on severe diseases, the number of hospitalizations from COVID. So we can track that, and you can see that there were a ton over the holidays, right? So the hospitals were packed with people who had COVID. Some of them are related directly to being sick from COVID, having pneumonia, being connected to a ventilator, but some of them were just people who were very frail, people who had bad heart disease or bad kidney disease, and even just getting a mild respiratory infection can tip them over because they had very little reserve and put them in the hospital. So we had lots of people who were there for COVID, but then also lots of people who were there with COVID. And so it was a very busy time. We got to very low levels, and there has been an increase in hospitalizations during this most recent surge over the past 2 months, but thankfully not as high as the original Omicron wave. And again, it looks like it's plateauing at this point. All right, and the other good news is that it does look like the overall COVID fatality rate is decreasing. That means for every person that's infected, the likelihood of death occurring is going down. And that's what you're seeing in red here, right? The COVID infection fatality ratio. And this is from July 2020, so 2 years ago. And it shows you that it was high initially, and then vaccines came out in January of 2021. We vaccinated our vulnerable groups first, and that led to a significant drop in the infection fatality ratio. We also had a lot of people who had COVID, so they had some level of immunity, and then we had people who developed immunity from vaccination, so that's what you're seeing in the blue there. And then it sort of plateaued, we gave people boosters, and it came down more, and then Omicron appears to be a more mild variant, and so there's less fatality with that as well. So it's gotten fairly low, sort of close to the level of sort of where the flu is at this point. All right, and so the CDC has had a tough job of trying to balance the precautions we're taking in the community based on the risk and based on the need to keep the economy functioning and not to overburden people with precautions as well. And so originally they were using this metric called the transmission level, which is basically a measure of how much COVID is out there. So these are current maps. I actually just put this up for this morning. And you can see currently, there's a whole lot of COVID out there, right? That's why it's all white, because it shows you that the level of transmission in counties across the U.S. is very high. And that's including in Philadelphia right now. There's just a lot of COVID, and I can tell you that just from being in the hospital and from employees testing positive and all that. What they recently started using is a community level, and this is based on not just the amount of COVID that's out there, but also how the hospitals are being impacted. So this is like the number of hospital admissions as well as the number of hospital beds that are being taken up by COVID patients. And what's nice about this is that there's a lot more green here, right? So Philadelphia was in the high range as of last week, or as of 2 weeks ago. It went down to medium, and then as of this week, it went down to the low level because hospitalizations have come down a bit and cases have come down a little bit as well. But still, again, lots of COVID out there, but thankfully it's not having a whole lot of impact in terms of hospitalizations. Does that make sense? All right, and there's lots more we can talk about the broader impact of the pandemic besides just the physical issues that come along with having acute COVID. There's long COVID, which we're learning more and more about, which may be due to either a dysregulated immune system or persistent virus or maybe clots. There's lots of mental health issues, particularly with essential workers and lots of burnout. If you work in medicine right now or work in hospitals, you know there's been a lot of people leaving the healthcare system, unfortunately, because of that. Healthcare systems have been strained because of the number of hospitalizations and because of healthcare workers leaving. It's exposed clear gaps in inequalities in care. So in the beginning of the pandemic, in Pennsylvania, if you look at the deaths that were occurring, 50% of the deaths were occurring in nursing homes. And that's despite the fact that maybe less than 2 to 3% of the population is living in nursing homes. But 50% of the deaths were happening there. So there was a clear gap in care there. There was a clear lack of infection control precautions. And so that's been exposed, and there's lots of efforts now to try to address that, as well as the inequalities in care that have been noted in minority communities. Lots of people also skipped out on routine care during those first months of the pandemic and since then. So missed cancer screenings, colonoscopies, pap smears, things like that, immunizations, and I think we're seeing the results of that of people presenting later with cancers that have progressed because they weren't caught earlier. And so I think we're going to be seeing the impact of that for a little bit. Kids have had missed schooling, which has had an impact on their development. And of course, there's been increased social upheaval and eroded trust in authorities since the beginning of the pandemic. All right, so let me transition and just talk for a second about masking. I think everyone here has been doing masking for 2 years now, so I'm probably not going to tell you anything that's totally new for you, but just as a brief review, right? So there's lots of different types of masks you can get. There are cloth masks, which is what many of us have been wearing for much of the pandemic. If you have a layered, finely woven cloth mask that's got 3 layers or more, that's better than a regular cloth mask. What we call a surgical mask, this is actually it's a procedural mask, is better than that. And then a KN95 is better than a surgical mask, and a fitted N95 is better than all of those. So a fitted N95 is an N95 that you've actually been tested for, and it's been demonstrated that it's actually providing you 95%.
And your glasses don't steam up.
Yeah, that's right. That's exactly right. Yeah. So when you are in a healthcare setting, you should really be wearing a surgical or higher level mask for protection. And the mask is playing 2 roles here, right? So it's playing the role of protecting you from droplets and from aerosols that are coming at you in the air. But actually, more importantly, what it's doing is it's providing what we call source control, right? So for people who have COVID and may not know it, which a lot of people don't before they're diagnosed, they may be asymptomatic or just have mild symptoms or don't think anything of it, it's actually preventing a lot of those droplets and aerosols from coming out. So really, for me, the primary reason to wear this is really to protect everyone around me, because that's the primary role. But again, it does provide protection for you. I think we still see a lot of this or this in the healthcare setting, or it's sort of all over the place. So I think one thing we can do is demonstrate to our patients that it's really important to be covering both the nose and the mouth, because if you're doing this, it's really not, there's lots of stuff coming out here. So really important to be covering both the nose and the mouth. I can tell you, there's lots of data out there that masks work. I'm not going to go into all of that, but I can tell you just from my own experience. So I do infection control in a hospital setting. And so I deal with exposures that are happening all the time, because we have employees who get exposed in the community and then test positive. And when they test positive, we find out about it and there's been exposures to patients, there's been exposures to other healthcare workers. I can tell you that in the hospital, if the employee is masked, we almost never see the patient converting to positive from that exposure. Because employees always have to be masked in the hospital, they're always masked. So they clearly work, and I can tell you that from my own experience. Yeah, so you know, the masks in the healthcare setting have really made a huge difference. I think you know, when we do see patients convert in the hospital or pick up COVID in the hospital, it's typically when visitors have been in the room, and oftentimes when visitors are in the room, they will often have their mask off when they're with family members or so. So those are the times that we've seen conversion. Questions about masks? All right, let's just talk for a couple minutes about vaccines. So, as you all know, I'm sure there are 3 vaccines that we currently have authorized in the U.S., 2 mRNA vaccines, Pfizer and Moderna. This is a somewhat newer technology, and then the viral vector vaccine, which is Johnson & Johnson. And basically what these vaccines do is they insert a little bit of RNA or DNA into the body, and they give the body the script to make a spike protein, which is part of the coronavirus. When the body makes a little bit of that protein, your immune system sees that and develops antibodies to that, but also keeps that in its memory, so it remembers that, so that when it is exposed to coronavirus or SARS-CoV-2 in the future, it's prepared, it's ready, it has that script there, and it can make antibodies much faster. And so you respond more quickly. So what you're really doing when you get a vaccine is you're giving your body a head start in tackling that infection, as opposed to it being some new, completely new virus to you. There's another vaccine that was put in for approval from the FDA from a company called Novavax. It's a little bit different than the other vaccines in that it's a protein subunit vaccine, similar to, for example, the hepatitis B vaccine that we've been using a long time. So hope is that since it's similar to other vaccines that people have been using, perhaps some of the people who didn't get the original vaccines might be more interested in getting this one. Vaccines and lots about the pandemic has become very confusing from all the terminology and the boosters and all the different terms that people are using. And I can tell you, even in healthcare settings, a lot of people don't use these terms appropriately. They don't understand what the current schedule is and all that. So I just want to mention a couple of these briefly. So the primary series is the initial doses that you receive of the vaccine. So for the mRNA vaccines, there's 2 doses, right? And the J&J, it's 1 dose. So that's the primary series. The booster dose is something we give after the initial vaccine response has waned. So that's a single dose for the mRNA and a single dose for Johnson & Johnson. For the mRNA, it's typically given 5 months after your primary series. And for J&J, it's given 2 to 3 months afterwards. An additional dose is for people who are immunocompromised. So if you're immunocompromised, those 2 doses of the mRNA aren't enough. You actually get 3 doses. That 3rd dose is called the additional dose, and for the Johnson & Johnson, the 2nd dose is called the additional dose. And so on top of that additional dose, you would also get a booster dose there as well. Fully vaccinated, which is, I would say, a less relevant term at this point, basically means that you got your primary series. That's what fully vaccinated means. Up to date means that you've gotten all of the vaccines that are recommended for you. So currently, everyone is recommended to get a primary series and a booster dose. If you're 50 and older, it's recommended that everyone get the primary series and 2 booster doses, or if you're immunocompromised, primary series and 2 booster doses. So you don't need to memorize all of that, but I just say that because it becomes very confusing over time, and I just wanted to make sure you're familiar with those terms. This is just the schedule sort of laid out for each of the vaccines. The mRNA vaccines, you get your 2nd dose between 3 or 4 to 8 weeks after the 1st dose. A booster dose 5 months later, a 2nd booster dose is 4 months later. Again, J&J is the 1st dose, another booster dose at least 2 months afterwards, and the 2nd booster dose can be 4 months afterwards. This doesn't apply to immunocompromised people, and again, you're up to date when all recommended boosters have been administered. All right, so do vaccines work, right? Are they helpful? Answer is clearly yes, right? So this chart on the right shows you the cases of COVID-19. The chart on the chart over here shows you deaths from COVID-19, right? So in the red are people who have received just the primary series, so not even the booster, or at least the primary series. And in the gray are people who are unvaccinated. You can see that Clearly, there's a lot less cases among people who have been vaccinated, and that's gone down over time. You can see the difference between those who are vaccinated and unvaccinated is getting closer and closer, and that's partly because of the newer variants that we're seeing that are a little more resistant to our immunity. But again, this also includes people who have not been boosted. On the other hand, our protection against severe disease like hospitalization and death has remained strong despite whatever variants that we're seeing here. So you can see the number of deaths among vaccinated people is substantially lower than compared to those who are unvaccinated. This is another way of showing the same thing. In black, you have unvaccinated. In the light blue, you have vaccinated with just the primary series. And then in dark blue, you have vaccinated with the primary series and the booster dose. And you can see the number of deaths that are occurring is substantially lower if you've been boosted as opposed to if you're completely unvaccinated. So here you can see the risk of dying from COVID-19 is 17 times less. That was as of March, so with these newer variants, if you've been boosted compared to if you've been unvaccinated. So the data is clear from both the original trials and the real-world experience that the vaccines work. How are we doing with vaccination across the U.S.? About 60-some% have been fully vaccinated, about 25 to 30% have gotten their first booster, and a much smaller percent have gotten their second booster at this point. So there's clearly still some work to be done there. In Philadelphia, about 1/3 of residents 12 and older have received a booster dose, so that's about how many are up to date. And this shows you the rate for 10,000 in different areas of Philadelphia. And again, this is the zip code where we are right now. So you can see there's a lower rate there as well.
Can I put in a little pitch? When you go around on your visits, you may have some of the vaccine ambassadors for Esperanza with you as translators. Let them do their 90-second version, and what they do, they're pushing boosters. Boosters, 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 boosters. So if anybody asks you, are you vaccinated? Even if you're vaccinated, did you get a booster? Did you get your booster? Did you get your booster? Thank you. Okay.
Yep. Love it. All right, this is I think the last slide, close to the last slide. And these are just the quarantine and isolation guidelines. These things have changed so much over the course of the pandemic. No one can remember them after a certain point. But that's why people like me are here. So, anyone know the difference between quarantine and isolation? What's the difference? So quarantine is what you do after you've been exposed to a virus, but you don't actually have it. Isolation is what you do after you actually test positive for a virus, right? So you quarantine after an exposure, and regardless of whether you're vaccinated or not vaccinated, because you can still get COVID even if you're vaccinated, it's true, we recommend a test around day 5, and it's part of the reason that all of you are testing around day 5 to 6. In terms of how long you need to quarantine, so if you are up to date, then it means you've received the primary series and you received a booster dose. In a healthcare setting, there's no work restrictions and no quarantine. And in a community setting, there's no quarantine required either. Although it is recommended that you mask everywhere. In a healthcare setting, you're always going to be masked. If you are not up to date, the recommendation in a healthcare setting, and so the reason these are different is because in a healthcare setting, we have higher standards, right? We're dealing with vulnerable patients who have the potential for more severe illness, with more potential to be hospitalized. People are there to be treated for other illnesses. You know, it would be a horrible thing for people to pick up COVID while you're there being treated for your cancer or for other illnesses. So we have a higher standard. It's the reason we use surgical masks there. It's the reason we have more strict quarantine and isolation guidelines. But if you're not up to date, the recommendation is to work restriction for 10 days or 7 days with a negative test. In the community, you might have heard that the recommendation since the new year has basically been 5 days of quarantine and 5 days of strict masking anywhere in the community. But if you test positive, similarly, there's a little bit more strict recommendations in the healthcare setting. 10 days or 7 days if you have a negative test, around day 5 or 6. And in the community setting, it's 5 days of isolation and 5 days of strict masking. Yeah.
So I know people who have gotten COVID, they're vaccinated, whatever. They're asymptomatic, and once they're asymptomatic, they don't have to test. But then if they, let's say that they do retest, and they're still positive, but they're not asymptomatic, or no, they are asymptomatic. So they're not contagious, and they can't spread the virus when
So you're saying someone's had COVID.
Yeah, someone's had COVID.
They've recovered from COVID.
Yes. Mm-hmm.
they test themselves again just because they have to get tested for a reason. They're not symptomatic. So you're asking, are they contagious?
But they have a positive test.
Yeah.
And then, what is it, like healthcare professionals, they told my friend who that situation that happened to, that they will continue to test positive for like the next month or so because they like have the antibody.
Yeah. So that's where it's important to distinguish between the PCR test and the rapid test. So the PCR test is really looking for molecular evidence that you had COVID. It takes a long time for your body to clear COVID after you've had it. So COVID gets into your body, the virus levels go up, and then your body clears it with its immune system. But there's still fragments of the virus flying around for a long time potentially, especially if you're older. And so that swab that they do for the PCR is really just looking for molecular fragments of the virus. And so what you're actually detecting after a certain point is just dead fragments of the virus. So that PCR test after you've had COVID can stay positive for weeks, potentially months. I've seen people stay positive for 6 months afterwards. Doesn't mean you're contagious, as you said, because the virus is gone, it's just dead fragments of the virus. The rapid test is really looking for more actively replicating virus, so it's a much better measure of, not that it's completely accurate, but it's much better than the PCR in terms of telling you whether you have active infection.
So are most of the home tests then rapid tests?
Yeah. Unless you're sending it out to a lab. I mean, some you can get by home and you can send out to a lab, but otherwise all the tests that you're buying over the counter and doing at home are rapid tests.
Looking for active disease.
Yeah. Other questions? All right, yeah, so just I would say on a personal note, the past couple of years for me have been very busy, but they've been occasionally challenging, but they've also been very meaningful because it's really been an opportunity for me to demonstrate the love and the compassion that we have in Christ to those around me, but also just demonstrate the faith that we have in something that's much bigger than the coronavirus. So I wanted to just leave you with these one quote and one verse. I'm going to replace the word molecule here with coronavirus. This is from R.C. Sproul, who some of you may have heard of, a Reformed theologian. But if there is one single coronavirus in this universe running around loose, totally free of God's sovereignty, then we have no guarantee that a single promise of God will ever be fulfilled. In the verse, Romans 8:28, and we know that for those who love God, all things work together for good, for those who are called according to His purpose. So, leaving with that. Because my two little ones at home, hoping they're napping right now, but happy to take any questions.
So
If we have time.
no, you do. Okay. We're back on schedule, Jerry.
All right, good.
You and I talk fast. So, any questions for Jerry?
Yes.
Also, in the news, I know that they're trying to emphasize getting like the vaccine out for kids younger than 5, and so once that becomes like more like legitimate, like trials and everything, like are you guys definitely gonna like act upon that once it becomes?
Yeah, so it's actually been approved. It was just approved this past week. So yeah, we're gonna get our kids vaccinated actually. So probably sometime in July. There's one that's applying for it right now. But, both of them. So I have one is turning 5 next week and one is turning 3 next week. So they've been waiting for a long time. Yeah, I mean, there's been, I'll say there's been, when these vaccines first came out, I spent much of my time speaking with people about various concerns and various things people have heard about the vaccines in the news. And unfortunately, people get information from all sorts of sources now. There's a lot of bad information out there on social media and other places, and so combating a lot of misinformation has been a lot of my job. But it's also the case with, as the vaccine gets rolled out for kids, there's probably going to be a lot of misinformation out there. It's important to keep on mind to address that. Other questions? I'm probably sick of hearing COVID.
Thank you, Jerry.